Again, thank you all for coming. This is likely to be a really fun day and fun morning. I want to introduce Kurt Stange to introduce the speaker. This is self-described as this will be our only speaker today because most of today is going to be spent in conversation and discussion. How many of you know Kurt Stange? Okay, so that sort of speaks for itself. So half the people in the room already know him. So I'll just say that Kurt is one of a kind. He's different. There's no one else in the world that's like Kurt. And he wears a lot of hats in different roles. But the most important thing I know about him is his imagination and his commitments to people and improving health. And he just has so many ways of stimulating and contributing to making things better, figuring out how to do things differently. So he'll introduce Heidi here, and then you guys just keep going and have a good time.
Thank you so much.
Thanks, Larry. Am I supposed to talk from the microphone because we're streaming this?
Privacy best.
So thank you, Larry. Before introducing Heidi, I just want to give a little bit of background to why we're here. So how many people know Rebecca Etz? So everybody, I guess this whole thing started with Frank and me talking about the interesting community work that's happening at both places. And Frank actually came to Cleveland and met with folks from the Cleveland Foundation. I think he brought the CEO of the hospital and the dean. He brought a bunch of muckety-mucks to Cleveland. And you know what happens when you have people, muckety-mucks coming from outside, you kind of put on your best face. And he heard about an initiative called the Greater University Circle Initiative that brings together so-called anchor institutions, I think named because they tend to weigh things down and drag things behind, and community partners. And so he heard about that, and they were very impressed. And he told me about this. And Heidi and I are working a lot on that initiative, and we know what it's like day-to-day slogging on the ground. And as you know, those things that you're working on day-to-day on the ground are not as good as they look when you put together a dog and pony show for people outside. And I had an inkling of some of the stuff that you've been doing here as far as community work, as well as all the great family medicine work and integration with mental health work that you're doing. And I also heard, Frank also talked about the great young people, the great rising stars, the people that are going to change the world that you have here. And I said, I want to get me some of that. And so we hatched the idea that it might be helpful just to get together to talk in a room like you talk with friends about your vulnerabilities and the things in your heart that you're really trying to do to make a difference. That, there's a Harvard business professor that Carlos Hyan, my friend, always quotes. Her name is Cantor, that says, "In the middle, everything looks like a failure." There's things that you're doing that you know in your heart are important, they're meaningful, but day to day often look like they're not going well. So we thought it'd be fun to just get together to meet each other and talk about that kind of stuff. So that's the kind of stuff we're hopefully going to be doing. We have a day of those kind of conversations where we'll be sharing what we're trying to do, sharing that maybe some of the problems we're having, and try to share what try to learn from each other. And I'm sure what happens when you're talking instrumentally about stuff like that, it ends up being social support to you. End up bucking each other up. You say, you're trying to fight the good fight too. You're having similar problems, and you just learn a little stuff from each other. So I think that's what the day is going to be like. But then I thought, well, Frank's going to invite the old guy that he knows, me, and he's got all these great young people that are really doing the work on the ground. And so he invited Becca, who knows your department well and is doing great work. And Becca and I are working together on the new Larry A. Green Center for Primary Health Care for the Public Good, which was just funded by the American Board of Family Medicine Foundation. So it's delightful that Becca is here because you know her work already, and she's worked a lot with you. And then I really wanted someone here who's actually really doing the work in Cleveland. And so I asked Frank if Heidi Gullet could come. So I'm finally getting to what I'm supposed to be doing, which is introducing Heidi. So Heidi is a family and public health physician. She did a 4-year combined family medicine, preventive medicine, public health residency at OHSU in Oregon. When you do a combined residency and get that done in 4 years, you have to take some shortcuts in your training sometime. I don't think she took many shortcuts because she came out of that training skilled in doing C-sections, practicing full scope family practice, went to Jellicoe, Tennessee, to fulfill her National Health Service Corps commitment, practicing full scope family practice. Then we were fortunate she came to Cleveland, worked in a community health center there. And even at OHSU, she'd worked in community health centers. She worked on a project with the state Medicaid office in Care, Oregon. And so she'd always worked really on the ground and looked at the policy level at the same time. So she has the ability to look at the big picture and really know what's happening on the ground. And we were fortunate then that we were able to recruit her to join the faculty at Case Western Reserve University. She and I both practice at a really operationally strong, incredibly mission-driven, wonderful community health center neighborhood family practice. And Heidi, as part of her faculty role, is embedded in our health department. She's the population health liaison for the health department. And she did that not as a project. She did that just because we wanted to develop relationships and have someone who was there day-to-day rubbing shoulders with people that are really doing public health work. So she's doing a lot of work. She'll tell you about, I won't steal her thunder, she'll tell you about a lot of the work that she's doing both on the ground and big picture. I kind of feel comfortable with this because I just got to introduce her a week ago Thursday night. She's an assistant professor, but got an endowed chair last Thursday night, which is a marker of how well respected her work is, both at the School of Medicine and in the community, that it was worthwhile to endow a chair, not because of someone has brought in millions of dollars of grants in the past, because of what she's doing right now and making things better. She also leads Block 1, which is where we start with our medical students for the first 5 weeks, and she gets them off to a phenomenal start. I mean, she radicalizes them. The radicalization's already there, but she makes it okay to try to be change agents. She also, last night on the plane, saw a friend of hers, and there was just a little funniness in her voice. She didn't think about it, and she woke up this morning with almost no voice. So she's going to cozy up to her lavalier microphone. She's got a lot of drugs here, and she's got a whole thing of water. So thank you for talking with us with whatever voice you have left, Heidi.
So can you guys hear me, at least to start? Okay, great. So I'm going to do my best. I'm sorry about the really annoying sound of my voice right now. I don't normally sound like this, I promise. Of all the days for me to have laryngitis, a day where I'm so excited to be with all of you. It's a little intimidating to come into a family medicine department like yours because I know the amazing work that has been done here for the last few decades. And it's really exciting to get a chance to learn from each other. So I'm really honored to be here. I'm going to share a little bit about what we're doing in Cleveland, but I am here to learn from you. So I hope that this is helpful context for what we're doing, and we'll give some detail so that we can pick up and have some really in-depth conversations over the next few days. I'm going to get another throat lozenge here. Sorry. I love this picture of Cleveland because Front and Central is our factory of sadness, which is also known as Cleveland Brown Stadium. See that orange right there? Yeah, right in the center. I'm a huge Cleveland Browns fan. I have been since I was a little kid. I grew up on the east side of Ohio. And we still mourn the 1987 drive 31 years later. We still sell T-shirts that say things about the drive. So you all have moved on. You have a few Super Bowl rings. We don't. So Front Central, but we are a lot more than just horrible football in Cleveland. And so I'm going to share a little bit more about how we're trying to bring the beauty of our Cleveland to the share.
As a child, My father would tell me stories of ancient Egyptian warriors traveling for endless days and nights across infinite desert plains, showing signs of endurance and bravery I could only dream of emulating. He would tell me that upon their return home, these warriors would be welcomed with a feast worthy of their bravery on the battlefield. Years later, as a teacher in Greater Washington, D.C., I too now find myself traversing a desert, though it is not the one I envisioned. A food desert. It's categorized as a poor urban area where residents cannot afford or are not given access to healthy foods and grocery stores. Every day at 2:45, I watch my students hop onto this leaking submarine of a school bus, every block bringing them deeper into an ocean where the only fish they find are fried, where fruits and vegetables just can't be found because there are no grocery stores here. Just liquor stores and Popeyes, Dunkin' Donuts and 7-Eleven's. Children born into a neighborhood that feels more pollution than solution. It is then I realize that I am not too far from the deserts I once dreamed of. See, whether Anacostia or the Sahara, it doesn't make much difference because to Whole Foods, Southeast DC is no different than the Serengeti. To them, brown-skinned little boys like my students are nothing more than walking cacti, just a piece of scenery this world has taught everyone to stay away from. Brianna literally has a landfill in her backyard, so she has a hard time convincing herself the world doesn't just think she's trash. Restaurants come and dump the remains of food she'll never be able to afford to eat 3 steps from her back door. Jose, he's fast food 5 days a week because his mother works 3 jobs to take care of 6 kids and only sees her son when she arrives home from work. At the same time he's leaving for school, he has gotten so big that the excess fat bunkered beneath his skin puts added pressure on his joints. His knees are literally crumbling under the weight of this world. Olivia watched her father shot 2 feet from her front porch. She wants nothing more than to go outside and play at the park after school, but gun violence has made a merry-go-round feel more like Russian roulette, so she doesn't go outside. Simply eats any processed food from the cabinet that will last long enough to prevent her from leaving the house too often. These are my students, my warriors, fighting a battle against an enemy they cannot clearly see. These kings and queens meant to feast, not to fester, but their zip code has already told them that their life expectancies are 30 years shorter than the county 7 miles away. I can see the faults of my own ancestry shaking in their eyes. Diabetes and high blood pressure run through the roots of my family tree. Heart disease is as much a part of my history as shackles and segregation. So from my father's kidney transplant to Olivia's asthma, these things are more than mere coincidence. Both grew up in places more accustomed to gunshots than gardens, so tell me place doesn't matter. Like the neighborhoods that are predominantly healthy aren't the same ones that are predominantly wealthy, because when you're not choosing between buying your medicine and your groceries, health doesn't have to be a luxury, doesn't have to be an abstract concept presented in academic journals and policy briefs. My students overcome more every day than I will in my lifetime. They are the roses that grew from the concrete, the budding oasis in the heart of the desert, and their lives are worth far much more than the things that this world has fed.
So that is Clint Smith, and his work has become really important to the work that we're doing in Cleveland, particularly around structural racism. And that video is something that we used when we were building capacity around understanding equity and the context in which we care for patients in our community, but also our community coming together to think about big picture population health issues. So I like to share that because that's all about context, and family medicine is all about context. How many of you have seen that video before? Anybody? Well, Kurt has, because he's heard me use it before. But so I would encourage you to check out Clint Smith and his work. We tend to use that also with our medical students, and it's been very impactful for them as well. So I don't have any conflicts of interest, but I figured the University of Colorado probably has something where everyone who talks here is supposed to give a disclosure. So that's why it's there. But I always like to say to people, I am a sold-out family and public health doc. I believe in equity, and I believe in the fact that we have to come together, learn from one another, and figure out how to best partner on the ground with our communities and our patients. And addressing the complex social determinants of health is our job and is our responsibility. And I know I'm speaking to kindred spirits, but it's not always the case when I'm talking to folks in Cleveland or elsewhere. That's one of the challenges that hopefully we can talk about as we move through the next couple days. All right, so I know I was hoping there were like some people who like their cell phones here, so I'll pull them out. The med students love when I use this because they can actually be on their cell phones and they have no idea. I have no idea if they're on Facebook or actually doing this. So this is Pull Everywhere. I don't know if you've used this software before, but basically just text my name with 063. Very, stroking my ego with my name in there, but it's the only thing I can get on a free account. So there you go. So text Heidi Gullet 063 to 37607. You'll automatically be in, and I'm going to do another poll question later so you don't have to do this again. So once you're in, I'll give you a couple seconds. Why family medicine? Why do we do what we do? Why does family medicine matter? And I would encourage you to keep your answers to like 1 or 2 words, if you can. Are you guys getting in? People subscribed? Someone is? Whole person health, awesome. So the word cloud might mix up, but we'll get a sense for the kind of words people are using. I love doing this with family medicine folks. It's a very different answer than what I get in a non-family medicine audience. And the fact that community is huge. I save these word clouds because I do these in different places. And I've never had community be the big one. So as you do this, the more it's used, the bigger the word gets. Beautiful. Relationships. So that's also something that I really like to underscore with our medical students and residents. Beautiful. And if anybody is on the video stream, you can do this remotely too. I meant to say that earlier. All right. Gert, are you talking about me over there?
No, I just kind of did one word 3 times. I feel bad.
Great. Awesome. So this might be my favorite one that I've ever gotten in an audience. So I'll send it your way when we're done with this. I'll email it to Linda. All right. Thank you all so much. All right. So I want to talk for a few minutes about why this matters to me. So I grew up in Youngstown, Ohio. Has anybody ever heard of Youngstown? A few people. All right. So it's a small town, old steel town, halfway between Cleveland and Pittsburgh, right on the Ohio-Pennsylvania border. That's what it looked like years ago. It was bustling, very active, blue-collar, working-class community. This whole left side, that's what it looks like now. And when I first came back to Ohio after finishing my National Health Service Corps, I got sent back to Youngstown. Never, ever had I dreamed of going back to Youngstown to practice. But I landed in a highly, I know this is being recorded, so I'll be careful. I landed in an interesting community health center. And it was very humbling to go back to the place I'd grown up. It was a couple miles from where I was born. And I realized, how powerful the social determinants of health, particularly unemployment and racism, were in the place where I'd grown up. I never understood the roots of that growing up. And so this work has become really important to me because I began to see people I grew up with who didn't know my married name coming into the office, parents of kids I grew up with, and was realizing these connections and how desperate things had become and how unhealthy the community was. So this work became very personal to me. And throughout my journey, I sort of was focused on the individual. I knew I wanted to do family medicine, but as I went through, I realized population and public health were so important. And so I did the combined residency. My voice is getting worse, I'm sorry. Yeah, maybe. So that even sounds bad too, but. So I did the combined residency because I wanted to learn about populations too. And so I began to understand the value of that in family medicine. It wasn't just about individuals. So when I got my National Health Service Corps assignment, I landed in a tiny little rural town in East Tennessee. Very white, very poor. And I began to learn a lot more about what community looked like and how family physicians were integrally involved in that community. And then moved on to come back to Youngstown and practice. That is one of our community health sites that had no windows. It was a rough little town, community health center. And I realized that we as family physicians have such a responsibility to address social determinants on the population and individual level. And so ultimately I landed back in Cleveland where Kurt was so that I could begin to learn from somebody and be mentored by somebody who's done this their whole career. So that's my family. We have those Cleveland signs. You might have heard we hosted the RNC. And one of the few things we got out of that was a nice airport improvement and 4 Cleveland signs, which are now tourist attractions. So this is me and my husband and my 2 kids showing another view of Cleveland. Anyway, and then during my residency, the other thing I forgot to mention is that Kurt sort of mentioned it, but I worked at Care Oregon, which is a Medicaid managed care company. And I was tasked with figuring out how to address the social determinants of health for about 100,000 members. I was minding my own business at my cubicle doing prior authorizations one day, and the medical director meanders by and goes, so I need you to give a presentation on social determinants, and then how are we going to address this for our members with finite resources? And I was like, I'm only here a year, right? I don't know how to do that. And he's like, figure it out. So that was a journey for me that began with really trying to understand models of addressing social determinants. And I'm going to talk, maybe if I have a voice in a few minutes, about the research that came out of that experience as well. So this is very personally and professionally very close to my heart. So I'm going to talk today a little bit about the FQHC where Kurt and I practice. That's really taken on social determinants and taken on population and individual health as absolutely the heart of what we do, and not taking all the barriers and obstacles that are set in front of us as excuses for why we don't get stuff done. The School of Medicine has been a very amazing platform for me, and it's also been interesting as a family physician in a very heavily specialty town. You might know of the Cleveland Clinic, maybe you've heard of that. The family physicians aren't the center of that institution. University hospitals, we have a very strong family medicine and community health department, but still very driven by specialists. Very different from where I trained. I trained at OHSU, family medicine is OHSU, right? So I'm learning how to be a very different voice in the School of Medicine, following people like Kurt. And then the dean put me 4.5 years ago in the population health liaison role with the Cuyahoga County Board of Health. And this has been transformational for me professionally. So I'm embedded 30% of my time at the Board of Health. I spend a day and a half a week, which is usually spread throughout the week, basically, doing all kinds of work with them, including getting our residents embedded in there, doing projects. So I'm going to talk a little bit about some of the big picture stuff we're doing. So this is half of our staff at the NFP. The other half wouldn't fit on the slide, but I wanted to talk about how we do teaching as well as population health and community. We are a group of folks who care as much about our patients as we do about each other, and I think that's really important. I think in family medicine, we care about each other and we try to build each other up. Life is too short to be working with people who don't believe in building each other up, but it hasn't always been my experience in clinical practice or in academics. So I finally feel like I've found a place where we can work together, and we have medical students, nurse midwifery students, undergraduate nursing students, preventive medicine residents. We're all about getting learners across the continuum in our community health center to do individual and population-based care. So one of the things we've been working on over the last 2 years is getting medical students, so those undifferentiated but yet idealistic folks, into our community health center paired with refugee families so that they can actually begin to build longitudinal relationship, the cornerstone of what we do in family medicine. They can see the joy and the beauty in what we do, and also the hard stuff that we do, before they get socialized into thinking that we make too little and we can't possibly make a living doing family medicine, which is not true. So last year we had 19 students, first-year medical students, through the first half of their second year. And 19 students logged 375 direct face-to-face hours with patients. And I've begun to get their reflections and our evaluation from the anthropologists we're working with. And the impact on their professional identity formation has been incredible. It has nothing to do with me, it has nothing to do with the other providers in the practice. It's all about getting them with patients and realizing the value of relationship. And so I wanted to just mention one of the things that we're doing in that regard around medical education, because we really want to try to impact folks and realize the joy of our specialty. We have very few students going to family medicine in our medical school. I have one right now who is a fourth year with us for her third rotation. And I just have to say that during her first year, she was with us, and she parked out in our lot out front. And someone had a really old car, and it caught on fire while she was rotating with us inside. And I saw this commotion, and we took a break from seeing patients to walk out front to see this huge inferno in our front lot. The tires blew up, and she realized her car was right next to this car, and it melted her car. And I thought, we've done it. She's never going into family medicine. She came back, said, I want to do family medicine, and no matter how hard it is. And now she's back with us as a fourth year, getting ready to match in a few weeks, hopefully in town. So I share that to say, even though we have challenges and the patients in our community health center have immense needs, it is such an honor to partner with them through all of these contextual pieces. And the students saw that. So our goal is to get students into environments like this really early on so we can keep them going. These are all pictures of real patients of mine, and I have consent forms signed by them or their parents for these photos. But I just wanted to share a few pictures of the folks. On the top is one of the families. They're from Syria. They're refugees. And 3 of their 4 children have a very progressive neuromuscular disease that I couldn't even find on PubMed. Very rare genetic disease. And a couple medical students have been partnered with them and walking them through a very complex healthcare system. And that was them right before the first new year. And it's just become a team to work with them. Our whole team has become like family. So I talked a little bit about medical education. Kurt mentioned the first block of medical education that we do. It's called Becoming a Doctor. And it's structured in the first week is population health. The second week is determinants of health, health systems, and then we move into patient-centered care. And they start in July. They get that in July of year 1. We start from the first week talking about health equity and what their role as physicians is in dealing with context. And for a few years, I've been doing this, a 6th year for me now. In the first few years, I got really obnoxious comments back about when's real medical school going to start? And this isn't what I came here to do. But the culture is shifting, and I still get a few of those nonsensical comments. And I encourage them to do pathology or something where they don't talk to people. But for the most part, they're actually beginning to understand the value of thinking in systems and thinking about determinants of health. And so we've woven into our small group, our problem-based learning, we call it IQ or inquiry groups. We've woven this curriculum into that. And we now have health systems curriculum woven throughout the entire 4 years. That's a work in progress, but we're getting there. So that's my most recent small group. And actually, one of them is coming to work with us for preceptorship in family medicine this summer. So I think we're getting there. So I start by telling these students, you need to be change agents. You should not learn the way we've done it for the last 50 years and keep on the status quo. Our health system is broken, and I need you and your brilliant minds to figure out how we go from here. So change agency is a huge concept that we use from the very beginning of medical school. And we try with our residents, but the problem is that our residents have been beaten down. And by the time they get to us, they're like, yeah, but I just need to get these patients seen and get these charts closed. And it's like, no. Like, I still want you to be able, as Kurt says, to raise your gaze and realize who you are and the fact that you can change the system as well as impact those individuals in front of you. So I've done a lot of work around learning health equity, and equity is specifically more than just health, in the work I've done with the Board of Health, and I'm going to talk about that in a few minutes. But I've also done a lot of thinking about what our role is in family medicine with regard to equity. What is that we do that makes us uniquely positioned to impact equity, to lead conversations about equity? And I think one of the things I've realized is that the voice of family physicians is really different than a lot of other voices around the table talking about systems and population health. We bring a very different perspective. So these are a few of the things that over the last few years have been really on my mind about equity in our role. So relationships are the cornerstone of our clinical practice. A few of the large health systems in our community think that family practice or family medicine is buying a few more urgent cares and getting people same-day access. That is not what we do. And longitudinally, continuity is really important to us. So influencing that conversation is really critical, and helping people understand that sometimes, as you all know, our therapeutic intervention is the relationship. It is not the medicine or the treatment plan. We also strive to understand our patients in context, and teaching in family medicine and public health residencies, I really try to stress this because I think our residents sometimes lose sight of that. You know, they're like just so in the weeds, they forget that you got to think about all these layers of context, the things that we're all trying to teach them. We're also very proximate to the social determinants every single day. And so what I've realized is that when I talk about examples from patients or the populations that we serve in our community at Health Center, people are like, you guys actually see that stuff in real life? And I'm like, every day. And so when I think about the really hard clinical days, like Tuesday night when I got home super late and had a bunch of work to do, I'm like, why am I doing all of this? I realize that I have a really unique window into understanding people's lives and what an honor that is, but also to influence that bigger conversation around policy and systems change because I understand what my patients are experiencing. We also prioritize all levels of prevention, and I'm annoying to the students and residents about levels of prevention, but I want them to understand it because they can't impact it unless they understand it. So our family medicine residents spend most of their lives in tertiary prevention. They're like dealing with diabetes complications and hypertension complications. But I also talk to them about the fact that quaternary prevention is super important. Who better than the family doc to stop someone from doing something horrible to them that doesn't need to happen, right? So we understand that inherently in the work that we do. And we also can articulate that to people outside of medicine and outside of our specialty. And then we also care for people throughout individuals and families and communities. And so I don't think I understood that until I was a few years into my career out of residency, the value of our role in the community. So this is Dr. Frieden's health impact pyramid. You've probably seen this before, I'm sure you have. But it's my favorite one of all the different infographics around social determinants. And the reason I like it is because it's pretty clear with some concrete examples. Like when I show the students this the first years, they're like, oh, I kind of get it now. I show it to them like 8 times before they kind of get it. But and I love the fact that what we do in family medicine is all of these. We never shy away from the hard stuff at the bottom of the pyramid that makes the biggest impact. And so I don't know about you, but I get really discouraged when someone comes in and I can't really help them come up with a plan to treat the poverty that's impacting their lives in really profound ways. But I can do stuff a little higher. So I've been trying to figure out how we can address some of those bottom of the pyramid things. So I'm going to talk a little bit about an intervention that we're piloting to try to get at some of that. So this slide talks about top causes of death, and I like to use this because, we in family medicine, we spend more time a little bit further to your right on this table. But I like the fact that this shows us how different groups of people think about causes of death and mortality. So in medicine, we typically think of all these downstream things, right? Like lung disease and malignancy and diabetes and things like that. But really, are those the things that kill people? Probably not. So this next group talks about what traditional public health thinks are really causes of death. What are the underlying things that cause malignancy and mortality? So these are where we tend to focus our population health interventions, right? Like, okay, tobacco control, right? We've been all over that for a while. Healthy eating and active living. We try to minimize people's consumption of things that hurt them. We're really all about controlling infectious disease. But the reality is that our collective focus, and this is what we're trying to do in Cleveland, is get our collective focus further upstream, further into the places where we know we can make the largest impact. And that's dealing with these structural determinants of health, the things that none of us were trained to deal with. I'd never left medical school or residency learning how to even talk about structural racism, let alone address it or treat it. But that doesn't mean we can't do the hard work of figuring out how we first talk about it and how we next address it. So I like to talk about this slide that give you an idea of kind of like where we're going in Cleveland, because our comfort zone is way over here. Like in medicine, our comfort zone is it's probably even further to the left, right? But in the public health world, we're totally cool here. We use a bunch of acronyms and we talk about our cool population health programs and we have some evaluation outcomes. But really, this is where we've got to be. And that's where we're trying to move the conversation. And I'll make these slides available. I know some people are taking pictures. You're welcome to take pictures, but I'll give you the slides too. So we in family medicine, I think, over the last few years have been working on population health definitions. There are umpteen population health definitions, and because I teach the med students, and because they always question me on everything, I'm pretty sure I've read most population health definitions that are published out there. But the one I actually have been using the last year and a half is one from the Health Policy Institute of Ohio, not because they're good colleagues down in Columbus, but because they've spent a lot of time thinking about this. So I wanted to just talk about this definition before we head into the next section. And that is population health is the distribution of health outcomes across a geographically defined group. And we typically use that. That's what we talk about with population health around payment, model changes, and things like that. But what I love about this is that this gets at the determinants, which are structural in nature, as well as all those behavioral determinants that we deal with day to day in our clinical practices. And the other thing about this is that it brings together the discussion about the healthcare system and the public health system. And because I don't know Colorado as well, I don't know how your conversations are going, maybe at the state level or more regionally. But in our community, public health and healthcare have been separated at birth, as our health commissioner says. We haven't worked together, and we haven't even had common definitions of things. And so population health, I believe, is that place where we can actually begin to have conversations in using some same language and figure out where we can be non-threatening to each other, but we can actually make a big impact. So this is kind of the frame that we use, the lens we use to talk about it, locally in Cleveland and in Ohio. So I have small children. They're the little ones who gave me whatever I have today, so blame them. I'm so sorry. We read that book about the blind mice touching the elephant. Many of you have probably heard of that. And everyone's touching the elephant in a different place, and because they can't see, they're all describing something that seems very different, but it's all a different part of the elephant. So HPIO used this a few years ago, and they let me use it in some of their talks, but I love this because this is kind of what we do with population health, right? Payers are like, population health, it's just my group of insureds, and it changes all the time. And primary care and family medicine and specifically, we're like, oh, it's my panel of patients, right? Some people may say it's my community, even if those aren't my patients. How do you define community? What's your service area? That's what the hospitals love. I was just in a conversation last week, and it was a very difficult conversation because the hospitals are defining their service areas very differently. How can we do an assessment of population health in our community if we have a different definition? Even if it's geographically defined, it's different. So how can we even possibly have a common conversation about what our community really needs? And that starts with asking people in the community. So if you don't know who the community is, it's really hard to get their opinion about what's going on. So I've talked a lot about health equity, and I'll show you a few infographics in a couple minutes. You've probably seen many of them. But the essence of what we're doing, teaching our med students and residents, and what we're doing with our community health center, and what we're doing with our county board of health and our city department of health in Cleveland, is we're trying to get a common definition, capacity around health equity. What is health equity? It's intimately tied to racial equity, but we started with health equity because we thought it was a place where everyone could at least kind of get their head around how we could work together. We are pretty tribal in Cleveland in that we don't communicate across sectors, and we have very different healthcare groups that don't communicate often. And so we sit in silos, and we do great work in silos, but not across that, and so our impact is small. So what we're trying to get people to understand is equity crosses those boundaries. It's about working together in a different way. And equity is at the center of that. It's about getting everyone an opportunity to reach their full potential. And that is very different than the way we've traditionally done medicine in our community and public health in our community. So this has been a way for us to get everyone around the table. And it's kind of messy work, and I really want to be clear. I may probably making it look kind of shiny in the next few slides. It's really hard, and it's really messy, and it's really difficult. And I have an entire whole webinar about all the challenges we've had. And I hope that we'll have a chance to talk about some of that, because I would love to learn how you've overcome what I'm guessing are probably some similar challenges. So, how many of you know the concept of redlining, banking redlining practices? Okay, a few people. So I'm going to talk a few minutes about redlining and then about how it has impacted our capacity building around equity and community health improvement planning in our community of Cleveland and Cuyahoga County. So this is a report. I will also make that available through Linda if you want to read it. But a few years ago, we were part of the National Place Matters movement. And that was all about learning local context and how that impacts health outcomes today. So going back decades, what decisions were made at the policy and systems level that has led to inequities that we see in health outcomes now, here. And so this was done in cooperation with Ohio State University and the Kirwan Institute. So this is a redlining map for the county of Cuyahoga County, which is where Cleveland sits. Cleveland is that sort of center, and then the airport is way over here on the left in Cleveland. Actually, the city of Cleveland comes around the airport, but everything else is more suburban. And so what happened back in the 30s was that after the Great Depression, the government wanted to try to find a way to stratify loans for the riskiness of the loan. So how can they put some criteria around how risky mortgages would be? And what it turned out to be was a really awful example of structural racism across 230 cities in this country, including Denver. And I have the Denver redlining map just to show you. So in Cleveland was one of them, Youngstown was another. And so what we see is that people in the red were given virtually no backing for loans or mortgages. People in the yellow had small amounts, and the green and blue was more. And so what you ended up seeing was that people of color were living in the urban concentrated areas. And it didn't put it in here for the interest of time, but when I send you the full report, you'll see there is astounding language in these statutes around people of color and how they were treated in the time of these redlining statutes. And the importance of this is that this is a very unfortunate legacy which has led to horrible inequities in health outcomes in our city and our county. And that's the basis of the community health work that we've been doing for the last 6 or 7 years. So I wanted to just show you a few maps. This is a poverty map from 4 years of combined data. And you can see the approximation of that same distribution, the urban core. And over here on your right, you can see the distribution of people of color in our community on the east side of the city where those mortgages were not backed. And I don't have it on here today, but the Latino community is just to the west of downtown and was also affected by these banking practices. You may have also been aware of some of the mortgage crisis that happened in Cleveland because it was nationally recognized as a pretty horrible thing. So you can also see that our high-cost mortgage loans and our foreclosures were very clearly mapped to those very similar distributions of the 1930s redlining practices. And probably the most striking is our life expectancy maps, and these have been replicated a few different years. But you can see that our life expectancy is dramatically different in those areas that were redlined. And at its worst, we had a 24-year life expectancy difference between communities to the east and the suburbs and to the urban core. And we've had several different iterations of those maps since. And we try not to highlight those particular communities because people in those communities are saying, we are tired of hearing how horrible our community is and how low our life expectancy is. So what we're trying to do is raise awareness around the fact that structural determinants of health impact every single person in those communities and the people outside of those communities as well. And they impact what happens in our exam rooms, in our community health centers every day. This is the redlining map of Denver. And I did a little bit of a search before coming here, trying to understand how these data have been used, these maps have been used in your community. And so I found a little bit about overlying this in gentrification and some housing opportunities and things like that. I didn't find a lot about health, but I may have been looking in the wrong places. But I'd love to know, as we talk more, if there are things that people are doing, because the same kind of things happen across the entire country and are impacting the inequities that we see all over the country. So this is one of the infographics that I like. There are a few floating around out there. But when I teach the med students, they're always like equity, equality, whatever. And I've been in a bunch of meetings with high-level administrators across different sectors in our community, including healthcare. And the conversations clearly indicate that there is not an understanding of equity and equality and the difference. And so this is a very simple illustration. And I know this room, everyone in this room probably gets it, but it's been useful for me, particularly with our students and residents. And this came from our Common Health Action colleagues in DC who trained us up with capacity around equity. So if I told you that Oprah was here and she had come ahead of us and given her favorite things, right? And underneath your chair was a pair of her favorite shoes. And they were all size 7 high heels. Like, raise your hand if a size 7 high heel would be valuable to you today. Right, okay, usually there's 1 or 2. Okay, great, I got 2 people today. Great, excellent. When I first did this, our health commissioner leaned over and he was like, what's a pump? So I don't use the word pump anymore. I said heel. So, great. So what if so that's equality, right? You all got the same thing, right? But what if I said, all right, what shoe do you need? Like, what do you have planned today? Do you need to get your 10,000 steps in? Are you going to be trudging through a bunch of snow? Are you going hiking? You know, we're in the West, so I can talk about stuff like that, right? We don't hike in the city of Cleveland very often, but we do have a nice national park a little drive away. Right, but I said, what do you need? What size shoe do you need? What's the width? What's the purpose of your shoe today? And then you looked and you each had that, right? You each had the right shoe and the right size and the right width for the right purpose for today. That's equity, because now you can reach your full potential of everything you needed to get done today. It's a simple and concrete illustration, and it's watered down for what it really means to have equity in a community, but it gives you an idea of how different those two concepts really are. There's another illustration of this that actually goes further, and it puts reality next to this. And it actually has kids of color deep down, actually under even the surface. So you can see that those structural determinants start people out at very different places in their journeys in life. So I keep a couple quotes at my cubicle in my clinical office. And the reason is that I don't know about you, but there are some days in clinical practice that are really, really hard. And I love what I do. I love being a family doc. I love seeing patients, and I've been in practice in Cleveland long enough to have had patients, few of my patients from Youngstown come to Cleveland, so I've had people now for about 12 years in practice. And I'm really honored about that. I love the fact that I've had the privilege to have a relationship with them over time. But there are days where I think the restrictions and the impact on our practice has given us a little ability to maintain the relationship and provide the kind of care that I came into medicine to provide. And what I think happens is our students and our residents see that, and they sort of lose a little of that idealism. So I try to remind myself, and also our team tries to remind each other why we do what we do. And this is one of the quotes I keep, and it's because I try to remind myself that I got to do what's right and what's best for that person in front of me every day. But I can't forget the fact that I got to be fighting these structural determinants and figuring out how we creatively address them at the same time every day. And some days I can't do both, but some days I can, and it's important to keep that perspective. So one of the things I've been doing at the County Board of Health as the liaison role, population health liaison role, is that I became co-chair of this big community health improvement process. I had no idea what I was getting into, and I think they didn't know who I was, so they were like, sure, go ahead. I had no skill set to do this work, really. I've built that over the last few years, and I've been mentored by amazing folks, including a few people of color who have helped me understand that being at the table is really important and not to walk away even when it's really hard to have conversations, particularly around race. In Cleveland, race is a very difficult topic. You've seen some of the national publicity we've had around race. It's hard everywhere, but there are some very deep hurt, and sometimes it bubbles up in places you wouldn't expect, conversations where you wouldn't expect, and sometimes it feels like, I don't know if I'm the right person. I'm an affluent white woman who's a physician. I'm not sure I'm the right person to be having these conversations. What I've learned through a lot of mentorship by my community colleagues is that I do need to be at that table, but I also need to learn how to take the lead from people of color who fought for the last few decades and who are looking for the next generation of folks who get it, who get racial equity and inclusion and the understanding of what that means for other vulnerable populations. So I wanted to share a little bit with you about what we're doing so that you could kind of see, but I wanted you to understand that I didn't come into this knowing how to do it. And I just had a conversation with one of our senior residents. He's a family medicine, finished last year doing a final year preventive medicine with us. And he does clinical practice with me on Fridays. And he said to me last week, I don't think I can do this work. And I was like, what? Like, we offered you a job already? Like, what are you talking about? And he's like, no, really, like, I don't know how to move between clinical care but this population health work, this is so hard. And I was like, I know. And he's like, well, how do you do it? And I was like, I don't know. You just figure out how to do it. I was like, Kurt told me a long time ago, it's the Nike way. Just do it. Like, figure it out. Keep at it. Keep going. And so, I realized that, like, I don't always articulate the fact that I'm learning as I go too. And he goes, this has been a liberating conversation. I was like, I know, it's therapy for both of us. It's great. All right, so our partnership started about over 10 years ago. This is a shortened version, but we did a community health assessment, and you may know that local health departments, in order to get accredited nationally by FAB, it's different than Kurt's FAB initiative, they have to have a community health status assessment. And you may also know that not-for-profit hospitals, in order to maintain their IRS exemption, have to do community health assessments. So in our community, those were done in complete isolation. So hundreds of thousands of dollars were spent on consultants to do all of these in complete isolation. And what we realized after our first assessment on the public health side is that cannot happen going forward. But it was the birth of our work together. So we're now, actually, this is a few years ago, or a year ago actually, we're now about 300 organizations and over 1,000 individuals who are part of our consortium. That does sometimes mean that all they do are get the emails, but we have a group of a couple hundred really devoted folks who are actively engaged. It's kind of a busy slide, but I wanted to just show you our framework, and I'll point out a few things. At the center, our outcomes are improving population health, improving well-being, and we don't have time to talk about exactly what that means, but hopefully over the course of the next 2 days, we can talk about how we are conceptualizing well-being. We're still trying to understand it. And then achieving equity. And it's not about health equity. It's actually about equity in our community, because we now realize the importance of equity with regard to economics and how that's so critical to health equity. And then we have 4 key approaches. The first is perspective transformation. And originally, when we did our health assessment, we came up with 4 priority areas, and I'll show those on the next slide. But one of them, because this assessment included 7,000 community surveys on quality of life, and we had a facilitated process of deciding what we were going to focus on, because we couldn't focus on everything. And through a number of qualitative and quantitative data gathering processes, including those surveys, eliminating structural racism came out as the first thing that we needed to tackle in our community. And when I talk to the med students about this, they're like, yeah, that's pie in the sky. Like, good luck. We're not sure how you're going to do that. And we're like, but you can't shy away from it because that's what our community said needed to happen. And so we actually moved from, after 3 years of having that as a key priority, we actually made it our number one approach. And that approach is in building perspective transformation and capacity in organizations to understand that racial equity and inclusion has to be a different way of thinking for our lives, for the way we do work, and it has to be a different way of doing business. And that is not an easy task, particularly in healthcare. It's an uphill battle, but we believe it's one worth fighting. We're also a collective impact approach, and I know that there are decades of experience in this community and collective impact, so we're newbies to this game. I did include a few things about how we conceptualize doing collective impact on the ground in our community, but I would love to hear about your work too. Community engagement is really our third key approach, incredibly important, and that doesn't mean that we come up with a plan and then we go and ask the community what they think about it. It means they're at this table every step of the way, including on our steering committee. It's nothing about me without me, and that's really hard to do. It's really easy for us as academics to say, yeah, we've studied things and we've collected some data and this is what we should do. It's very different to have community at the table saying, this is what it's really like on the ground in our community, and this is what you need to do. They're usually very different perspectives. And our fourth approach is health and equity in all policy. And there are a few examples of where we've been successful, but we haven't been that successful in getting state and even county level policy to think about health and equity in each policy they create. So this is a challenge, but we continue to come back to a vision where everyone in our community, in our county, we do county level at this point, has the opportunity to reach their full potential. So this is where I've been spending the majority of my time for the last couple years. I wanted to just show you our status assessment. So we did a status assessment. We looked at a bunch of publicly available data. And I'm up at night thinking about the fact that we're doing another assessment currently for 2018 and 2019. It's really complex, and actually getting into the granular level of detail on the data sets that are available around vital statistics and things is a real challenge. We also did a community strengths and themes and strengths assessment, and I can talk later in our small groups about what that looked like if you're interested. We did a forces of change assessment, and this is particularly important when we start talking about the hospital systems and the federal changes to health policy. They're really like, we've got to talk about these forces of change. And then we did a local public health assessment, and it was really interesting to see how people think about our public health system. We also did a community photo voice project with a bunch of adolescent youth, and I wanted to show you these. So I talked to you about race and how big of a challenge that is for us. So that was one of the pictures around race. And then this one is where have all the hoops gone? And that actually wasn't even in the city of Cleveland. It was one of our suburban communities where all the basketball hoops had been taken down. And these students and these young students had nowhere to play and exercise together, build community. So these were our 4 key priority areas. I mentioned limiting structural racism, healthy eating and active living is another one, as well as linking clinical and public health. And that's the work that we're doing there is really around bringing the hospitals and the public health departments together for combined assessment. And it is really hard because they think about everything very differently. We're actually at the point of having all but one hospital system agreeing to a combined assessment, but I'm not giving up hope that we can get them to the same place, at least maybe by 2020. The state of Ohio has now put in statute that they have to cooperate, but they don't know always exactly how that gets played out. And then chronic disease management, and we've uniquely focused on hypertension, combining healthy eating and active living, produce prescriptions, shared use agreements in certain neighborhoods with high rates of heart disease and census tract level. So that's what that project is, and that's been largely supported by CDC grant REACH, which is racial and ethnic approaches to community health, which has been massively cut by the current administration and will end in a few months. All right, so what is collective impact? You all know, I'm sure, what collective impact is, but we like to show this to our partners because we're really good at individual impact. We're kind of good at coordinated impact periodically, but collective impact is a whole new way of doing business. And in our community, it hasn't been the way we've really wanted to work together over time, and we're trying to change that. So we're trying to get everybody to have an understanding of collective impact. These are the 5 conditions that we use in our community. And context so matters for this work too, because one collective impact initiative and the way it operationalized in a certain community may not work in another community if you don't think about context. So even though these are the things that all of the collective impact scholars across the nation publish about, it looks different in Cleveland than it does elsewhere. The common agenda has taken us a few years to create, but it's been equity-based, and that has really helped. Now that we have common language, and I just 3 weeks ago got an invitation to have a conversation at the state level about a state common definition of equity that will be used across a bunch of healthcare organizations in the state. And I almost fell off my chair because we're having this conversation at the state level. I was like, this is great. I don't want to have too high of expectations, but to me, that's a really good movement forward. Shared measurement. This is really hard. No one wants to give their data up. They're like, you can pry it out of my cold, dead hands, particularly the hospitals. And I'm like, come on, people. The universe of EMR and billing data and public health data, what we could do with all of that and understand things is immense. But no, we want to just have market share and talk about the fact that our service areas might be competitors. Like, that's unacceptable when you think about equity. So we're continuing to have some conversations about that. Mutually reinforcing activities. People have different concepts about what that means, right? Just because you come to my meeting and I come to your meeting doesn't mean we're mutually reinforcing one another. In fact, it might mean you're stealing everything that we just discussed, including all the data, and going back to your sphere and using it for the betterment of your organization. And we've had some hard conversations about folks we don't think are doing what that calls for. Continuous communication. People don't read email. So how do you get them to communicate in a way that's authentic and fosters long-term relationships of mutual respect, which are essential for collective impact? And then backbone. So our county board of health has put immense general revenue into being the backbone for this. And so we're trying to figure out now, after 10 years, how do we support them going forward? Because they can't continue to use GR for something like this. So these are from the Collective Impact Forum. You've probably seen these before, but I wanted to highlight some of the things that intersect with our world in family medicine. Relationships of trust and mutual respect. That's what we do on an individual level with our patients and with each other. But this is about community partnerships. Hugely important. Local context, also hugely important. So these are things that we're trying to embed. And every month I try to do a collective impact corner with our steering committee, and sometimes it works and sometimes it doesn't. But we're determined to get people to buy into this model. Equity, this is a nice article from Policy Link, and so we just try to remind our group every time that equity is the soul of what we're doing, and it's not easy, but we've got to keep that at the heart of what we're doing. The other thing I wanted to point out is that equity and equity lens are different, and sometimes in our steering committee we get into conversations about this. Equity is that outcome we're looking for, everyone having an equal opportunity to reach their full potential. But using an equity lens is filtering everything that comes along and thinking about how do we apply that lens. And that really has big implications when you're talking about health systems and the policies they put in place. How do they use their community benefit dollars? How does a business in the community think about equity? That's very different. So we're trying to help also move that conversation forward. I also wanted to just highlight that this is an aha moment I had about a year ago, reading some of this work and then reflecting on our own work. So we sometimes get criticized for being too intentional, strategic plan is too clear and outlined. And then on the same token, we get criticized for being too whimsical and following whatever is the thing of the day. And I'm like, come on, man, you're one or the other, right? But there's this beautiful tension between being intentional and strategic in this kind of work and knowing where you're going and having enough strategic direction that people don't think you're crazy or that you haven't put the work into it, but also being nimble enough to act on those things that come your way and are emergent and ready to make a difference. And so I had to come upon this by having this experience of a couple things happen to us and a lot of criticism on both sides to realize that I'm really going to need to get comfortable in the space between these two worlds. if we're going to continue to do this work. And so I really am trying to get the rest of the steering committee, and my co-chair agrees, both of us are singing from the same song sheet on this, that if you want to criticize us for not being strategic enough, that's fine, give us your guidance. But you got to be ready when those emergent opportunities come, because we're going to jump on them, and they're going to come. When you begin to work together differently, you realize potential and possibilities that never could have been imagined in the old way that we were doing business. So I've already talked a little bit about the forces of change assessment we did 10 years ago. Obviously, the forces are a little different now, but there are a lot of things going on. And I don't know how it is here at the University of Colorado, but in Cleveland and in Ohio, all of a sudden the healthcare systems are like, we do population health. And I'm like, really? Because public health's been doing this forever. And we're conceptualizing it differently, right? So there's a new clinical interest, and there are actually some healthcare administrators in our community who have said, we don't actually know what we're doing, and we really do need public health. And that, to me, is a really golden opportunity that's pretty time sensitive to get working together. So I think that's an important force. This whole alternative payment model and value-based reimbursement, I think, is also another driving force for us in this sphere. And then there's an interesting discussion in our community about the role of healthcare providers individually and as organizations in addressing the social determinants. We in family medicine have been living this for years, but it's now at the level of administrators, and some interesting conversations about the fact that it's not our job. It's not our job. That's outside our walls. I had a student write on an evaluation. I'm not sure if he read that. I sent them to Kurt, but he wrote, I don't understand why I got to learn about this stuff. It's not a doctor's job. Sure is a doctor's job, right? And it sure is a hospital administrator's job. So we're trying to figure out, what does that mean? And how far do we own dealing with the social determinants inside the clinical walls, inside the hospital system walls, through our community partnerships? And then there are a lot of innovative patient-centered care models, which, if used in an equity frame, probably will be very impactful, but it hasn't always been the way that we've done it, at least in our community. So for the last couple of minutes, I just want to share with you, I'll switch gears just a little, about some research I've been doing with Kurt, under Kurt's mentorship, around poverty. So I mentioned that, that bottom of the health impact pyramid is really important to me. And so when I was in my cubicle at Care Oregon 10 years ago, more than 10 years ago, I started searching for models, and I found Bridges Out of Poverty. How many of you have ever heard of Bridges? A couple people? Okay. So I ordered the books and read them, and I was like, wow, this makes a lot of sense. It's a great framework, right? It's not perfect, but it's a great framework. It's what I live in my FQHC. So I ordered all the rest of the books I could get, and eventually went and got trained in the model, and have been using it with residents and med students for over a decade. But I got to thinking that there were a lot of great programs built on this model, and how amazing would it be to use these with our patients to help them move out of poverty, because I can think of numerous examples of how poverty has really impacted my patients, including leading to their deaths, preventable deaths. And to me, that's unjust, and I can't live with that. But I don't know how to treat poverty. So I'm trying to test out ways that we can do this pragmatically in primary care settings, which are chaotic and challenging, in which I don't have time. No one's giving me time to treat poverty. They're like, you've got to get your 25 patients seen for the day. And, I can't treat poverty in that time frame. So we're doing this, and we're just at the beginning. Bridges' work defines poverty as the extent to which individuals do without resources, or have without resources. So there are 11 resource areas that we use, not just money. Typically we think about money, but as you all know from your experiences in the community and with your patients, resources are a whole lot more than just money. And poverty is not the middle class with less money. There are realities of living without resources that really impact day-to-day living and impact people's ability to have a future orientation. I find it really hard to convince people to have a colonoscopy to prevent something that might happen in 10 or 15 years when they're not really sure they're going to be alive in 10 or 15 years, and they're more worried about their kids' incarceration or their violence on their street, or things like their ability to get food. So my hope is that this work leads to the ability to do something that's scalable to help people move out of poverty in a very concrete way. And really the framework is about helping people think about how class impacts their own thinking. So I also combine the work with these patients and work with people who are serving, so people in these teams, to think about how do we think about people in poverty and how do we interact with them. We're very middle class, and we have a very middle class way of operating in healthcare. And our patients don't always know the rules that go along with the middle class way of doing things. But we've been socialized, most of us have been socialized from the time we were little to live in the middle class world. We go to the bank, we go to school, we have graduate degrees, we're able to work in a professional world. Those are not things that many of my patients have ever experienced. So we really direct teach ways of operating in the middle class world so that people have ways to get out of poverty. It's not as simple as I'm making it, but I want you to have a general idea of that idea behind it. So this has also meant that we're partnering cross-sector. So we have some amazing partners. It shows you the sustainability model, but my biggest partner right now is a workforce development and social service agency called Ohio Guidestone. And they have actually put up the support to do the backbone for this as well. And this is not in isolation from the thing I just talked about, but it's working together. This is a bunch of the different books, and I'll give you these slides, but this has been really transformational for me personally and my career as well. And these are the programs that we're testing out with patients and with employees. So there's a version for people returning from incarceration. There's a version that's just for all comers. That's the one I'm using with patients. And then there's a version for the workplace, and we're trying to test this out among entry-level workers in healthcare, because the other realization I've had in the last few years is that I cannot provide high-quality patient care and see the number of patients you're demanding that I see and provide them with a relationship and do what's right for them if we don't have a team that's highly functional and stable. And I've worked in a number of community health centers with a revolving door of staff. That is not helpful. We cannot do this well, and it means that we're not actually supporting our employees. So we're trying to do this to stabilize our workforce and get people opportunities for growth internally. There's also a version of this for youth that we're doing in some of the schools around the Cleveland area. And then, just like Bridges as a framework, this stability model is a framework for administrators and for managers. And so I had the opportunity to do this with a couple large healthcare employers over the last few months. And I did it with my own FQHC, which was really dicey. I was like, ooh, I don't know if this is a good idea or not. But it did, and I wasn't sure how it would play out. I'm still sort of figuring out how it's playing out the last few months. But one of the medical assistants came up to me and she said, I heard you did some kind of training. And I was like, oh no. And she said, I just want you to know my manager, she's doing things differently. So whatever you said, keep saying it. So I thought, well, okay, we've at least made a difference in a little way. And I'm almost done, I promise, we're at time. But this is one of the things we talk about both with people living in poverty and also people who are administrators and providers, is that this is one example, and I thought it might resonate with you guys, is about relationship. And so frequently, if you think about a relationship as an exchange withdrawal, like a bank account that you put money in, you take money out. Well, we do a lot of things with people living in poverty, and their deposits, they're really good things, are the things that our residency faculty taught us to do, right? Like, we're trying to be helpful with goal setting. We're trying to use an adult voice, not tell people what to do. All the things we learn with solution-focused brief therapy and motivational interviewing, the things we try to do as family docs. But I'm guilty of doing all these withdrawals too, and I see them happen a lot. And so our goal is to try to teach people concretely about how we can better partner with folks. So this research is all about not just does this model work with patients or with healthcare staff, but does this model work with all of us who are trying to build relationship? So one of the biggest ones has been around language, and our staff are really good at using parent voice and telling people what to do. And we're really trying to shift that movement to the adult voice. And so that has been a thing that people have latched onto, although all these are really important. So I just wanted to quickly mention that poverty simulations. Do you guys do poverty simulations? Have you done one before? Yeah. So we began doing these because I have had a hard time recruiting people to do some of this Bridges work. They're like, it sounds so amazing, but then they never return my emails. So, or like when I show up, they like smile and then find, no more eye contact and go away. So I've realized that poverty simulations are a really great way to sensitize people to the experience of living in poverty, but also to build awareness around our need to actually address these structural determinants. And then you give them that pragmatic way to plug in. So I just did one yesterday with the Cleveland Clinic talent acquisition human resources staff who are in charge of hiring those entry-level jobs, environmental services, food service, patient care attendants and things like that. And it's an opportunity to talk about how you're impacted. In an hour, you spend a simulation of what it's like with an identity of someone living in poverty. So we can talk about that if you're interested, but it's been a helpful tool for us. All right, so we're just at the end. I just want to tell you that this has been a really important quote for me. I got you a couple quotes. It's really long, but I talked about the gist of this at the beginning of my talk. And I think the medical students come in and think that we're just training them to be doctors, to look like doctors, act like doctors, talk like doctors. And I don't want them to be doctors of old. I want them to be change agents for the future. I don't want them to be indoctrinated into the way we've always done it, because it's not working and it doesn't serve patients and community. So I use this as a motivation for myself to say that we really want them to leave our curriculum and leave our training sites along the medical education continuum, creatively addressing reality and discovering how to be agents of changing that reality. And that's a really different way than I was trained, but it's the way that I really hope we can impact our world. So I'm going to skip this because of time, but I just want to thank you all so much for bearing with my horrible voice and for having me here. It's a real honor, and I'm really excited about the next few days. So thank you so much.
Question and a comment.
Yeah.
The question is, would you be willing to run for president?
I was telling Becca that I was actually putting the poverty simulation kit together after my clinic because I realized there were some pieces that were not correct places, and I had the State of the Union on. That was a poor decision. And I thought, how ironic is it that I'm sitting here putting a poverty simulation kit together, listening to this rhetoric. And I did everything I could to refrain from assaulting my television, but I've been very discouraged, and I really hope that we can encourage each other during times where it's a real challenge to make this a reality, this kind of work.
So I won't put you in the running, but collaborating with hospitals seems like a logical thing to do in trying to promote health. But until the payment system changes, the hospitals are in a different motivating fashion. So I think the mission statement for most hospitals is to make as much money as is humanly possible. And so Bob Phillips and Andrew Bazemore came in and gave an example in Boston where they developed a diabetes clinic for the hospital that really improved the care of the community, but they found that their amputations and dialysis patients were going down, so they closed the diabetes clinic. And so they're really not, unless legislatively there's a greater demand for community benefit, not the ideal partner to promote health because they like people being sick to come into their hospitals. But thank you for your talk. It was really very motivational and good.
Well, thank you so much for your comment. And it fully resonates with me what you're saying. I just wanted to tell you that in Ohio, the governor has, we have an enigma of a governor. He's a Republican governor. You might have heard of him. He was running for president at one point, John Kasich. But, and he passed Medicaid through a back channel reform. But interestingly enough, he's requiring our hospitals to collaborate on these community health assessments. And he actually is publicly reporting their community benefit buckets against national benchmarks, and it just went live a few weeks ago. And I met with a bunch of hospital folks last week around all this community benefit stuff, and there's a buzz and a concern about what that is. And so I think you're absolutely right, and it's got to be a big payment model change because there's no incentive for prevention and doing what we all believe is best. But it's been interesting to see their mindsets change at least a little, and we have a couple hospitals that have actually, their leadership is thinking differently, and I'm hopeful that they'll push a few other folks to think differently. But in the absence of those, forced things, it's really not working in our community either. So, thanks. I know people may need to head out, so I'm happy to take questions, but people need to head out. Yeah.
First of all, amazing talk. Thank you. I know I can speak for Heather and I. We're feeling really inspired over here, and Heather is now officially gunning for the equivalent of your job in Colorado.
Thanks.
So I've been writing down a lot of comments over here, but I'll stay focused. How you ended with your example of kind of more discrete actions that you are taking to try to address what we really think is impacting health. Your example of poverty, I think, was really inspiring for me because I think, we're learning more and more that we care about social determinants of health, but physicians either care and feel lost or care and feel scared to address it or are not exactly sure we should be addressing it at all. But from a research perspective, I'm wondering if that really made me feel inspired to think maybe we should be collecting these success narratives of whether they be physicians or just primary care teams as a whole, of people who really are confronting this head on, instead of just kind of timidly dancing around it, or just saying, let's collect this information and think about it later. So I'm just wondering if if anyone's looked into that, and if we could gather success narratives and learn and feel inspired about other people also doing this.
Thank you so much. I think that's an amazing idea. And one of the reasons that I'm here is to figure out how to work with all of you and figure out how to do this kind of stuff, because I do get really discouraged, and there's days and I'm having trouble with recruitment, not because people don't think this is a great idea, but because my medical director said, "I'm so sorry, I forgot about people recruiting for your study." And I was like, "You were my big champion." And he's like, "I just have too much going on in clinic." And I was like, "I know, but can you just ask somebody if they want to participate?" So it's we have these real on the ground challenges, and we can polish it up, make it look nice in a talk, but doing things that actually disseminate our shared successes and our shared challenges, I think would be very impactful. So
yeah, I think we could totally appreciate inquiry and gather some data before. Cool.
Awesome. Thanks.
I have a suggestion. You can see the design of the day. Let's take a break now and reconvene one floor up. We walk out of the auditorium, the 200 number rooms are not upstairs. In that break, I think Linda Niebauer should go print out a bunch of diplomas. And if you come back for the rest of the day, at the end of the day, we'll get Heidi to sign your master's degree. That was 8 3-hour courses shot through the fire hydrant in an hour and 10 minutes. It was truly amazing. But we've got time to unpack it again, to talk about it with one another. So hoping that you stick with us for as much of the day as you can. Heidi, I think you also need a doctor's certificate for inappropriate use of your voice when you're sick.
I was Googling, I was like, there's nothing. I'm a medical manager on how to deal with laryngitis in an emergency. I need to talk in an hour.
Amazing content and amazing statement. Thank you very, very much. We'll see you soon.